All right, welcome everyone. This is shadowing session number 50. We're very excited to have everyone on. I can't believe we made it this far. I mean, the year has flown by, but we are so happy to have you on. So today we are going to be joined by Rodeline. She is a PA who has worked for 6 years. She's worked 4 years in emergency medicine, and for the past 2.5 years, she's worked in urgent care. Just a quick introduction, and she's going to be talking more about her own journey and more in her presentation. But quick few reminders for those who are listening, especially if you're new. So towards the end of each of these sessions, we do have a Q&A. If you do have any questions for Rodeline, either now or as we go, feel free to type them in the chat. We're going to go through them in the order that we receive them, and I'm going to be reading them out to her. So that's one thing. Another thing is we do have more shadowing sessions to come. So if you do want to stay updated, we do have our Instagram page. That's likely where you probably heard about this session here. We have flyers that we post on our Instagram page with details about our speakers and when those sessions are going to be. We typically operate around a Monday and Thursday schedule at 7 p.m. Central. So that's when you usually can expect us, but sometimes there are some changes. So for example, next week, we're not going to have a session on November 24th, which is Thanksgiving. So that's something to keep in mind. Things like that, you'll be updated through Instagram. Another way that you can stay in tune with us is our email listserv. So this is basically the same thing as our Instagram page, but just in email format. We still attach our flyers. We do also include opportunities like, for example, our volunteering programs, our mentorship program. We post those both on Instagram and our listserv, but you'll just get a little more consistent feed in terms of our mentorship program being opened up or our volunteering programs being opened up. And right now, this is the time of year when we do have those programs opened up. So we do have our applications for Code Blue Mentorship, which is our mentorship program, Medical Miracle Mission, and the Student Refugee Mentor Initiative. All three of those programs are opened up. And there's also our PDI application for any of our Florida folks, especially if you're in the Tampa area. That's going to be applicable for you. It's an in-person clinical volunteering program. But with that aside, those were just some details. You can join our listserv by going on any page on our website, going to the very bottom and subscribing through there. So include your email. We suggest a personal email and your name, and you'll be good to go. Or you can email us at shadowing.h4h@gmail.com, and we'll manually add you on. If you have any questions, you can also reach out to that email for any questions outside of what I just mentioned. But don't want to take up too much time, so Rodeline, feel free to take it away.
Thank you, Michael. Hi guys, my name is Rodeline Joseph. I'm a PA, as Michael said. I've been in healthcare actually for 14 years. And got started as a licensed practical nurse and then became a PA 6 years ago in August 2016. And I'm also the founder of a tech startup called MedSembly, and we are a digital mentorship-driven career resource tool connecting students and early career professionals to mentors and resources geared to help them succeed. You can think of us as a virtual career resource center. So I'm very happy to be here and help all of you. And most of my work has been in the ER and urgent care. So the cases I say today are centered around that and giving you guys some background in how it is working in both specialties. Yes. So I am a PA in urgent care and ER. These are two very similar settings, but there are differences. Urgent care is, like the name says, for more urgent cases, and ER is emergent. So it's all based on the patient's presentations and their needs and the resources that they may need and their stability. We'll go more in depth with that. But they are very similar. I like both because they both involve acute care and kind of seeing patients and treating them and treating them as, they present as what they present with and kind of seeing them get better. A lot of these patients, you can see them get better in front of your eyes, given that it's like acute conditions. Some of them, of course, may need to be admitted or transferred, or, then they'll eventually get better, as time progresses or if they go home with treatment. But yes, I really like acute care. Okay, so Whether you work in the ER or urgent care, one thing I always tell students, I do virtual shadowing as well. And I don't know if some of my shadowing students are on here. So you guys probably already know, if you watch my sessions on ER and urgent care, how I go about it with these type of patients. You always want to be thinking worst first. Worst first because of the setting. So these are people that are sick, and you really, when they come, you don't really know what's going on. And especially in the ER, you don't want to underestimate a patient's presentation. You don't want to like just kind of overlook it and think that, oh, it's nothing. You always want to think worst first. And by that, I mean, like, what's the worst possible thing that can be going on, and rule that out. And you're not going to rule it out by just ordering like any type of test. You're going to basically kind of do it systematically through your history, through your physical, through then ordering the necessary labs, the necessary imaging, then going like, doing your differential diagnosis and determining and consulting as needed, or talking to your attending physician as needed, to then determine the likely diagnosis that this patient has. But you always want to think about like, what's the worst possible thing, and rule it out in your decision making and in your H&P that you do. So if someone comes in complaining of chest pain, you always want to be thinking, oh, making sure it's not a possible heart attack, especially depending on the patient's age. Like a 10-year-old complaining of chest pain, of course, less likely to be a heart attack versus like a 50-year-old. So if a 50-year-old came in complaining with chest pain, then you're going to do tests, but you want to ask the right questions to say, oh, do I do like a troponin to make sure it's not an MI, or, do I do an EKG? Of course, there's always going to be tests that's a given, but by worst first, you want to think about like the right questions to ask to make sure that's not it, and then doing the proper documentation to ensure that you ask the right questions and covering yourself. So it also, thinking about like what can kill your patient. Is the patient sick or not sick? And by sick or not sick, I mean, like, are they like acutely sick? Is this somebody that's going to be admitted? Is this somebody that just doesn't look right? Somebody that, you're just having thoughts about and like, I'm not too sure about this person. You're going to be thinking about your pearls. Pearls are just kind of need to know type of things. You'll learn more about those in school. And then your differential diagnosis are like the usually three diagnoses that you think could likely be going on. You will have like a bunch of diagnoses in your head, but then you'll narrow it down to the 3 top things that you think could be going on. And then you'll have your like actual diagnosis from there. And then you'll always be consulting with specialists or with your attending physician. Okay. So how it works in the ER, and basically kind of like the urgent care, but urgent care they don't really assign levels, but the ER, so you will, a patient will walk into the ER, they'll be seen by the nurse, or like the front desk people, and then be seen by the nurse, they'll fill out all their paperwork, and then the nurse triages them. And from there, they're like asked, certain questions, their vitals are taken and assigned an ESI level. And the ESI level is the emergency severity index. So that kind of tells you how sick or not sick the patient is. So it's levels 1 through 5. And that also determines like kind of like where they go in the ER as well, and the type of resources that they may need. So level 1, a patient may not walk into the ER, likely won't walk into the ER if they're a level 1, hopefully not. Level 1 is basically, you can think of like is dead or dying, a cardiac arrest, someone that usually comes in via EMS, and not like someone that just kind of walks in and standing and looks fine. Level 2 is, you can think of as like kind of near that, like a respiratory failure, someone that just is really, really bad, is likely going to be admitted to the ICU. And then level 3 is what commonly PAs can also see, of course. PAs can see any level really. But most commonly, I feel like from my experience and like just where I've worked, they commonly most see like level 3s and down. They can see level 2s as well. They can help with level 1s. And depending on the ER, some ERs, it's just one provider. So the PA may just be like the only one there and they see everything. Those are called critical access hospitals. or critical access locations, but for the most part, it's going to be like level 3 to 5. 3 is kind of in the middle. 3 is like, they'll definitely need some blood work, but in terms of admission or discharge, you just kind of don't know. But 1s and 2s are most likely always admission unless they're like improperly triaged. And then 1 and 2s are going to need like the most resources. So they may need all these blood works, all these, tests, these imaging, all these specialists. So yes. And then 4 and 5 are like pretty like, like kind of urgent care type of patients, like cough, colds, flus, earaches. 5 can be like somebody that's coming in to get their sutures removed and they're just in and out. They don't really require too many resources. And then from there, they're assigned a bed assignment. The nurse will assign them something in the ER, and the bed assignment can be dependent on the level of severity. So patients that are really sick may be closer to the nurse's station, so they'll get a good eye on them. And then patients that are like level 4 or 5 are like in the fast track area. And then they'll be seen by somebody, and they'll either be seen by a PA, an NP, or a doctor, and we'll assess, treat, diagnose, do everything to make sure that patient's good. And then it's kind of the same flow in terms of urgent care as well. We don't necessarily, we don't really necessarily provide like ESI levels in urgent care because everybody's kind of like a 4 or 5. And if we think they're not, then they're going to go to the ER. But yeah. Okay, so the way that I'm going to do these next presentations, I don't know, they're not able to like respond to anything, right?
There is a slight delay. So usually what we'll do is we might have like the question and then we'll move on to the next slide and we'll circle back just because there's a slight delay.
Okay, no problem. So these next few slides are basically helping you guys determine like the proper, the way to properly treat this patient in terms of the setting. Is it okay to treat this patient in the urgent care, or is it going to need more and need to be going to the ER? Because the last thing you want to do is have a patient come to the urgent care and you think that, oh, it's urgent care. Any patient that comes to the urgent care is going to be urgent care. And that's not the case. You still want to have that level of discernment and say that, no, this patient is, even though they're coming to urgent care, patients don't know. They're sick. They might think that, oh, I can just go to like a quick clinic or whatever, when in fact they can't. So I want you guys to tell me if you think that the patient is where they should be, or if the patient needs more care in the ER. If the patient's in the ER, should they have been in the urgent care? Or like, just let me know where you think that you treat this patient, the best place to treat the patient. Okay, so this is a 58-year-old male that's presenting to the urgent care complaining of chest pain and shortness of breath. So this is like basically a lot of times what you're going to get their chief complaint and their vitals, which really is like some of the most important things that you'll need. Everything else you'll basically get from talking to the patient. So you want to look at their vitals and their chief complaint. And then of course you're going to look at how the patient looks. Both going to do a subject and objective. So you'll all that will help you determine things. But just from this should give you a good idea about like what you're going to be working with as well. And if this could be someone that needs, further care. So tell me, you guys, if you think this patient, this 58-year-old male, if he should be in the urgent care or if he needs more care in the ER. All righty, so I'll move on, and then you'll once I move on, then we'll go back to that. And you can just let me know when you see some answers. Okay, this next patient is an 85-year-old female that presents to the urgent care complaining of abdominal pain. So you guys are going to tell me if this patient should be in the urgent care or if she needs to be somewhere else. And when you guys put urgent care or ER, also give me the indication, why do you think that they should go to the ER? Why do you think that they should stay at the urgent care? What's is there something in their vitals, or is there something in the chief complaint, or is there something about them that makes you want to say one over the other? Okay. Are there any responses for the first one?
Yeah, two responses that are for urgent care, but not necessarily like a specification as to why yet.
Okay, no problem. So I can like go over this as long as there's some responses. So the first one is a 58-year-old male that's coming into the ER, coming into the urgent care, complaining of chest pain and shortness of breath. So I would not treat this in the urgent care. I would definitely send this patient to the ER because of the complaint and because of the patient's age. So this patient is older in age. It can have you're not going to really see their like if they have any comorbidities. And even if they don't, just the age it can be a risk factor for cardiovascular disease and ACS. So the age, you can ask you to take into consideration other things like maybe they're a smoker, maybe they have family history, but the fact that they're having chest pain and shortness of breath, and then their vitals are a little off, so the pulse, they're a little tachycardic, their heart rate is 113, and then the oxygen's 95%. The oxygen's still okay, but it's getting on the lower end. So it's like a, lower end you can think of as 90 to 94, below that, of course, but 95 is just kind of you want it to be, of course, 98, 100%. But what would be concerning to me is the heart rate. And of course, the fact that they're having chest pain and shortness of breath in a 58-year-old male. So you want to think about heart attack. You want to think about possible blood clot, especially with the tachycardia or the fast heart rate. You just want to think about the worst things that, you may not be able to fully do in the urgent care. There's no monitor in the urgent care. What if it is a heart attack and, you can't really see that, you can do an EKG, but yeah, this patient would need more care. And then, so because they would need more care, so in the urgent care, when you determine that a patient should not be in the urgent care, you have to then decide, is this a patient that can go to the ER safely on their own, which means privately owned vehicle, so a POV, or is this a patient that will need to be transferred via an ambulance? There's some gray area with certain things. A lot of it's also going to be to provide a comfort. But this patient, I may send them via an ambulance, especially if they drove themselves. And, you'll also see how the patient looks to you if you just kind of don't feel comfortable or how you feel. But this patient, I'll probably recommend an ambulance. If they deny or if, decline an ambulance, some people think it's too expensive. Some people think that, they look fine. They can just drive there. Just make sure you document that. Document. Okay. The 85-year-old female, what do you guys think? Any responses for that?
We have two for ER because of blood pressure and age.
Okay, so blood pressure. Blood pressure is kind of funny in the ER. So we don't even really treat blood pressure in the ER unless they're symptomatic or certain measures. But 160/74 is actually okay. We don't like to, do too much for asymptomatic hypertension or high blood pressure. The 160/74 is actually fine for us ER providers. But her age is concerning for her, right? And abdominal pain. So basically, just about anybody that comes in with abdominal pain, they're going to get blood work just to make sure it's nothing surgical. It's nothing like appendicitis or a pancreatitis or whatever it is. They're going to get blood work, if anything. But given the patient's age, she could have all these things going on. She could have, more comorbidity. She could be at risk for certain things. So you definitely want to be precautious with older patients, older as in over 40s, especially when they get to their 80s, 70s. You definitely want to be a little more careful with these patients and patients that have a lot of comorbidities, which older patients do. So this patient, I would send them to the ER to get some blood work and a CAT scan. A lot of providers, they will not send an 85-year-old home without a CAT scan. If they come in complaining of abdominal pain, they would definitely do a CAT scan, of course, with blood work and everything as well. But yeah. And let's see, for this patient, I was going to say something else. I think that's it. Oh yeah, POV or ER, ambulance. So this patient, her vitals look fine. If she's with a responsible person, like her son or daughter or whatever, somebody drove her, I would be okay with them driving to the ER. A lot of times ERs are not too far away from like urgent cares or other medical facilities. And as long as they seem responsible enough to take this patient and make sure that this patient gets the proper care in the ER, I would be okay with POV, especially if she looks fine as well. You'll look at the presentation, but yeah. All right. 6-month-old boy presents to the urgent care with mom following a burn to his genitals while taking a bath. I made this one a little harder. Okay, so 6-month-old boy presents to the urgent care with mom following a burn to his genitals while taking a bath. So you guys see the vitals. In kids, we don't do blood pressure before a certain age, of course. So what do you guys think? Tell me, what would you treat? Like, what do you think about this patient? Do you think that, it's a burn, they're in the urgent care, it's fine, give them some, I don't know, triple antibiotic or something, like or Silvadene, like what would you do? So just let me know. All right, we'll go back to this. Okay, a 12-year-old girl presents to the urgent care complaining of right lower abdominal pain. Another abdominal pain. And just an FYI, like a lot of what you see in the ER will be abdominal pains. That's like one of the most common complaints. Other common complaints are like chest pains, musculoskeletal like injuries, like ankle injuries and knee pains and stuff, a lot of pains, headaches. So tell me what you guys would do for this 12-year-old girl. She's having right lower abdominal pain. And you look at her vitals. Do her vitals look okay to you? Is this somebody that she'll just treat in the urgent care, or do you think she needs more? All right, so we're going to go back to the 6-month-old boy. So what do you guys think about this patient?
So we have quite a few responses here. 3 ER, and then 1 urgent care. For the ER, it really just depends on how severe the burn is. That's what our students are saying. And then urgent care, I mean, on that same line of thought, if it's not as severe.
Okay. So, okay, good. So burns can be tricky, but burns to the genitals, always, 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 always concerning. So this patient would definitely actually need to go to the burn center. I mean, the ER, but like the burn center eventually. So especially given their age and the burn and where the burn is, those are concerning. This actually happened before, and like this patient had to be airlifted to the burn center, but not good. No bueno. Burns to the genitals, burns to certain areas. You want to worry about. So if mom comes in just, like, oh, it's just a little burn or whatever, you got to do your due diligence. Thankfully, this case was not like just an urgent care. It was like an ER, but you want to, like, anything involving the genitals, you want to send them to a burn center. But everything else, like the vitals look fine though. Okay. And I would probably call an ambulance for this kid, just to make sure, just because like another important thing is like our kids, like pediatrics, like I don't really play with kids and older adults because they're so like negligible. So yeah, I'm always careful with kids. And then a 12-year-old girl presents to urgent care complaining of right lower abdominal pain. What do you guys think?
So all responses are saying ER. Low blood pressure is one of the reasons. One said low right quadrant pain, so that could be a potential appendicitis.
Good job. So her blood pressure is actually, I mean, for her age, she's probably small, little, she's 12. That's not really concerning, but you'll probably look at the map too, like mean arterial pressure. But what's concerning to me though, it's like she's has a fast she's febrile, she has a fever. So that could be appendicitis, especially with the location of the right lower abdominal pain. So you'll definitely want to take her to the ER to do more tests. So good job. ER is correct. In terms of POV or ambulance, for the most part, I'll trust parents when they say they're going to take their kids to the ER, because I think parents are super concerned about their kids. So if they say they're going to go, then they're likely going to go. If the daughter doesn't look too sick, if she's not like actively vomiting, or she doesn't look like you're not super like worried and you're like, oh, she needs to be in an ambulance, she may be okay to go in the via POV, like with parents just kind of take her, but it's all going to be based on presentation and how comfortable you feel. But yeah, I mean, she has a fever, maybe ambulance. We'll see. I mean, things just change in real life, but maybe ambulance take her. But yeah, either way, she needs to be in the ER. Okay. An 88-year-old female presents to the ER from urgent care for right hip pain after a fall. Her x-ray at urgent care was normal, but now she's in the ER. So what would you guys do? Okay. So we're gonna go to the next one and let you decide. And then a 25-year-old male with history of HIV presents to the urgent care complaining of a cough. All righty. So tell me what you like, if you think that he can be treated in the urgent care, or if you think he needs to go to the ER. So we'll go back to this one. Any responses for this one yet?
Not so far.
Okay, no problem. So for this, just think about like, why would a patient go, they're already seen in the urgent care, and if they say that the x-ray is fine, why would they then go to the ER? Think about that. If you don't know, I can also say it.
Yeah, no responses so far. So if you want to spill the beans on that one, it's fine.
Okay, so so if a patient, so this patient, I would, they were in the urgent care, for instance, and now they're coming to the ER, even though they had an x-ray. Even if the x-ray is normal, you still want to, like, don't just kind of tell them, oh, your x-ray is fine, you're going to be fine. Take people's complaint of pain and complaint serious. So if he's coming to the ER and he's concerned, what I would probably do next is a CAT scan to make sure that there's not an underlying fracture. Then this actually happened to me before. They had an x-ray and we did a CAT scan, especially if they can't walk. If they can't put pressure, if they can't bear weight, then and walk at all, then you want to do a CAT scan. So, and they don't have CAT scan in urgent care. So you want to do a CAT scan for this patient to make sure there is no fracture, and that's happened. So we've did an x-ray, and the x-ray looked fine, and then we did a CAT scan, and lo and behold, there's a fracture. But the patient's 88 years old. Ortho might not do anything, or ortho didn't do anything, like in that case of that patient. They were admitted for pain control. I mean, but it all depends. But I think that the patient is where they're supposed to be. It's fine to be in the ER after feeling like, you're still not feeling any better. And we tell patients that, we say that, if you're not any better, go to the ER. If you go to urgent care and you're still not better, go to the ER. So yes. Luckily, vitals look fine. Okay, any responses or any thoughts on this patient? 25-year-old male with history of HIV presents to the urgent care complaining of a cough.
So we have one for urgent care because the cough and the vitals are stable. Doesn't seem like it would be intense enough or urgent enough to send to the ER.
Good job. Yes. So, I mean, this patient, like, I feel like the word HIV might throw some people off thinking, oh, they're sick, they need to be in the ER. But no, like most patients today, especially with HIV, with medications, they're fine. Like a lot of them are undetectable with proper medication and compliance. And even when they get sick, if their CD4 count, doesn't fall below a certain amount, they're not going to be as like negligible to like, opportunistic infections and crazy illnesses and whatnot. So this patient with the cough, they can, get a chest x-ray, make sure there's not a pneumonia, they may give antibiotics, given their medical history, but it could just be the flu, it could be, a virus like most coughs. So he's where he's supposed to be. His vitals look fine. If he doesn't look super sick or anything, you can treat it in urgent care and just let them know if it doesn't get better, you're getting worse, whatever, go to the ER. Good job. Okay. 25-year-old male presents to urgent care complaining of burning on urination. 65-year-old male, I'm sorry, presents to urgent care complaining of burning on urination. Okay. Look at the vitals, look at other complaints. I mean, the chief complaint. And then this one, 32-year-old male presents to the ER complaining of a laceration to his knuckles. You see the vitals and everything. So we'll go back. Okay, 65-year-old male presents to urgent care complaining of burning on urination. What do you guys think?
No responses so far.
Okay. While we wait on that one, I'll go to this one and talk about lacerations. So lacerations they can be treated really in the ER or in the urgent care, both, but it really depends on the type of laceration and the depth and like the severity and complexity. So like if it looks straightforward, if it's, doesn't look like, underlying tendon injury, if you're not concerned for like any complications or anything crazy, then they can be treated in urgent care. For other things, you definitely, with lacerations, especially in the hands, you definitely want to do a proper assessment. It's people's hands. So when you're working with someone's hands, that's a high risk of liability, because imagine like not being able to use your hands. Imagine having an injury and then the effects of that no longer being able to use your hands. That's a big lawsuit. So you want to definitely do a proper physical, do a full and good assessment, look at the full depth of it, make sure that there's no possible like tendon injury, make sure that they have full range of motion before and after suturing, or if you do end up suturing or not. If you're concerned, hand specialist, hand surgery, please make sure that they have proper follow-up and talk to a hand specialist if you feel that you need to. That is so important, because you don't want to be the reason, or you don't want them to say that you didn't do the right care and now they can't use their hands, especially if they use their hands for work to make money. Then you got to fund their lives. So we'll get back to this, but any responses for this, the urgent care burning on urination?
So they're saying ER because of high temperature and burning. Another one is saying age and febrile.
Okay, good job. So you guys are getting the hang of it. So this is a 65-year-old male, so he's older, and he has a fever, and his heart rate, his vitals are off. So when you're looking at like vitals and possible infection, you want to always remain cognizant about sepsis. So sepsis is like a complication of like an infection, where your body's having like a hard time fighting off the infection, and you kind of have like develop this thing called, you could develop SIRS and sepsis, and you're just like having just a hard time just getting rid of the infection, and it can just really take over your body, just kind of really explaining it as basic as possible. And so there can be like, it can lead to tissue death, and just bad stuff, like you can lose digits because your body's trying to your body's trying to spare core organs. So other things that like your skin and digits, like it's just kind of you'll have the tissue death because as your body's trying to protect your other more important organs. But that's like severe sepsis. But you want to be cognizant of sepsis because it can lead to bad stuff and tissue death and death just in general. So you with the temperature and the pulse, you want to and because they likely have a UTI, you want to send this patient to the ER so they can get the proper labs and IV antibiotics, because that's what it's pointing to, especially given the patient's age. This patient could have had like enlarged prostate or prostate cancer or something that's making him at risk for UTIs. They could have a catheter in, you don't know, it's a fake patient. But yeah, just be thinking about that. And have a high index of suspicion for sepsis when you see these type of vitals and like a known infection. So they're going to need IV antibiotics. They're going to need labs. They're going to need like a sepsis workup. So yes, ER they go. Okay. Anything for this patient?
No, not yet.
Okay. So I'll tell you guys this patient. I was actually asked this when I first started working in the ER. I was asked this at an interview and I didn't really get it right. And so it always stuck with me because I didn't really know about this. So this laceration onto the knuckles are called fight bites, and they're at high. So it basically, the doctor told me, oh, the patient punched something, so they punched something in the wall. And I'm like, okay, if they punched something in the wall, then I guess suture it up. But he basically said that, you never want to suture fight bites, or it's a fight bite until proven otherwise. So you're gonna, even if they say it's from a punching in the wall, you're gonna treat it as a fight bite. A fight bite is basically from fighting, like, someone's teeth hits, your knuckle hits the tooth, or, and then they bite you. The mouth is very, very dirty. So human bites are nasty, high risk of infection. The patient's going to get antibiotics, but closing that up can lead to even worse infections. So they say not to close these type of wounds up, and just do it. Some literature, like some stuff I read. I mean, I would probably talk to my attending physician on this, or talk to like hand. But some stuff say, of course, call hand specialists. They may need to like wash it out. Do of course proper like cleansing, but talk to a specialist to say, what do you want me to do about this? I think that's the best thing to do. What do you want me to do about this? Because of the risk of infection, and that's how the patient got the injury. So, but even though it's a laceration, you'll say, ooh, laceration, I want to close it up. But because of where it is, just make sure that you cross your I's, dot your T's, and make sure that, your attending physician knows about it, or that, are you okay with, this proper plan of care? So before you go suturing anything up, see what they want you to do. And if they're, talk about the injury. So it's not something, the fight bites, knuckles, you're not going to go straight to close it up. Okay. 75-year-old female presents to the urgent care with her son following a syncopal episode last night. We see her vitals. She passed out. Syncopal episode is passing out, and it happened last night. She's fine right now. What do you think? All righty. Next one, a 30-year-old female presents to the ER complaining of the worst headache of her life. What do you think? Okay. Keyword for this, I put WAST, I meant worst. Keyword for this, you're gonna learn this in school, or keywords, worst headache. When you hear that, you have to protect yourself. You have to do, like, especially if the patient puts it in the chief complaint or whatever, you have to do certain things because they say worst headache. I'll explain later, but let's go back to this. So a 75-year-old female presents to the urgent care with her son following a syncopal episode. Her vital signs look fine. Say she looks good. She says, oh, I'm good. My son is just worried and annoying, and he just told me to come here to get checked out. What do you guys think? Any responses? Okay. So this may be a little tricky, especially if she says she's good, but remember she's older and she had a syncopal episode and it happened during the middle of the night. Who knows if anyone witnessed it? I would send this patient to the ER to get worked up. Because she's older, it could have been a cardiac event. It could have been a neurological event. It sounds like it could, want to rule out cardiac, especially. She could have had injuries from it. There's just so much to kind of figure out. And the best thing is to get proper blood work and to rule out ACS and, anything else that, why did she pass out? Why? So like I said, you don't want to, you don't want to play with older patients. They have more conditions, they have more, a lot of comorbidities. Say this patient had a heart attack before and she could have had another heart attack, or she could have had, just anything. She could have very low blood anemia, or she could have very low blood sugar. You got to just do a proper workup. Okay, so this female with the worst headache of her life, what would you guys do? Should you do ER, urgent care?
We have ER, although I'm not sure if this is for, they're numbering it. So they're saying question 9. I'm not sure if this was
Okay.
I think this was the 9th one, but they say age is a concern.
Oh,
Sure.
maybe the 75-year-old, that's 9. This one's 10.
Yeah.
Either way, but I'm okay. So the 30-year-old is not necessarily her age that's a concern, but the fact that the keyword worst headache of her life. So you guys will see this on an exam one day. The word worst headache of her life or of his life or whatever. That should tell you that it could be a subarachnoid hemorrhage. It's like a brain bleed, and you should do a CAT scan. Subarachnoid hemorrhages, like if you're bleeding in the brain, that's a true emergency. A patient can die from that. And that's what we're taught in school. When a patient says like it's a terrible headache, they can't control it, just a thunderclap, it just came out of nowhere, they're vomiting, they're just, you'll have like, your suspicion. But if the patient, you're going to ask the patient scale of 1 to 10, they say 10 out of 10, it's the worst thing ever. It's like, whatever, you just got to do it. Or I would just do it to cover myself, but it's just that worst headache of her life. And people might ask you, why are you doing a CAT scan on her? But you're going to document patient said worst headache of her life, or patient, said 10 out of 10 patients having this, that symptom. Other risk factors are if they've had like family history of like aneurysms, or if they've had like family history of like other subarachnoid hemorrhages. So some people can have risk factors, but that keyword worst headache, at least on the exams, that it's going to be subarachnoid hemorrhage. So that's something for you to remember when you take your exams in a few years. And other than that, vitals don't look terrible. So that is it. So hope you guys enjoyed it and have a better understanding of ER presentations versus urgent care. If somebody comes to the ER and it's like an urgent care complaint, oh, wow, they're in the ER, you can treat urgent care in the ER, but you can't treat ER in the urgent care. So, yeah, and ER has like, they can take level 4s and 5, they can take urgent care patients, they can take anything. But you got to remember, if you're in the urgent care and you think a patient needs to be in the ER, even if they might not, especially when you're new, it's better for you to sleep at night. It's better for you to sleep at night than to kind of just act all willy-nilly. It's better to be like, kind of over like precautious and kind of scared and just doing things because you're new, than to just risk possibly hurting someone because you're not taking proper precautions. So it's okay to do things just because you're not sure, and send them to people or send them to areas where they may get better care and have more resources and others. Because when you start working, especially as a PA, you might work alone in the urgent care. So it's fine to send it and to not be sure and to say, oh, I think you need to go to the ER. So yeah, that is it. Thank you so much, guys. You can contact me and reach me in these methods. And thank you again. Thank you, Michael, for having me. And open to any questions.
Absolutely. Well, first of all, thank you so much. I mean, not only for me, but I'm sure the rest of the students would be saying the same if they were here on the call. This was such a great presentation, especially, the divide between urgent care and emergency. It's a fine line. Not many people even recognize that there is a difference to begin with. They're just kind of interchange a lot of times, but there is definitely a difference. And also, I mean, on the back end of things for patient costs, there also is a difference. So this is definitely a choice that on the side of patients, they need to be making just as much as we are with triage. So definitely thank you so much. Let's hop into questions. And by the way, for those who are listening, if y'all have any questions as we go on, feel free to type them in the chat. We still might get a chance to get around to them. But our first question here is, you mentioned a lot about the specialty in specific, but just as being a PA in general, why did you choose to go to that field, just in general, being a PA?
Yes, good question. So I decided on PA. I actually decided on PA when I was actually super lost in life. I didn't know what I wanted to do. I started college off being pre-med, and like after like my first semester, I was just like, I don't think this is for me. But I didn't really know what was for me. And I then switched to nursing because I had my LPN, but I didn't get into nursing school. I mean, I only applied to like 2 programs, but I still didn't get in. And I'm just like, okay. Then I switched to sociology, and I, just kind of was figuring out, like, I spent most of my college trying to figure out what I was going to do with my life. And then it was my senior year. I was at work one day, still not knowing what I wanted to do. I was just at work. I didn't get my patient care hours as an LPN because I wanted to be a PA. I just was working as an LPN, just FYI, because I did it in high school, and because it was good money. So I was working as an LPN, and I was at work one night, and I saw the words PA on the chart. I would see PAs kind of walking around, but I just never like put 2 and 2 together. I never like really thought much into it. And I just didn't know what they were there and doing until I did research. And that's when I like realized, that, oh, the PA career is this and the PA career does that. And I have like patient care hours to get into PA school. And I had like other, credits and classes. And it just kind of fit not only like what I kind of already had, but like just my profile and my personality and what I wanted for my life and my future. Just, the flexibility with working, even though I basically stayed in one specialty, just the opportunity to do that. And being able to, I'm not a big school person. So like being able to like kind of get, trained and get out there and start like working rather than like being in school for a more extended period of time, that was attractive to me. And also the fact that, there's so much flexibility. I felt like, I wanted to pursue different passions, and the PA career has allowed me to do that. And yeah, that's like one of the main reasons why I chose PA.
Okay, so quite a few questions rolled in. First one is, because of the field that you are in now, did you work as, or did you know of this at any time ahead and work as an EMT? It sounds like you had clinical experience ahead of time, but did you ever work specifically as an EMT during undergrad or any step along the process?
No, I never did EMT. I didn't even know what any of that stuff was. Like I mean, I didn't know what a lot of it was. I learned, but no, I just did LPN. I didn't know that I wanted to go into ER urgent care. Actually until I did my rotations. I thought I wanted to do OBGYN. And that's why I tell you guys, you don't have to know, especially if you want to be PA, you don't have to choose a specialty, or you don't have to really know. You'll figure it out. Like, I mean, you don't have to ever know, because you can do as many or as little things as you want. You can do them simultaneously as well. But I thought I wanted to do OBGYN until I did rotations. And I'm like, oh no, I don't want to do this. And then I did ER, and I just fell in love with it. I love the variety. I love that you see so many different things. you'll have 8 patients, for instance, 8 patients at a time, and they all have all these different things going on. You could have a patient with chest pain, abdominal pain, headache, knee injury, laceration, this, that, you know? So it's all so many opportunities to learn and grow and build on your skills. So I like that, rather than like kind of just doing cardiology and just seeing like all cardiology related stuff, or, you know, pulmonology or OBGYN and just seeing all the mother and baby. But that's just me. But yeah.
Okay, next question is, what would you say your favorite part of being a PA is?
Um, my favorite part of being a PA, let's see. My favorite part of being a PA, I would say, has to be just for me, for like me and the person that I aspire to be in my life goals, is really, really the flexibility of the PA career. Like there's so much flexibility, like it's like crazy. So, and I mean that comes from, you can do that in certain healthcare careers as well, but like I just feel like PA, like I was able to, oh shoot, sorry, my lights just kind of went out, but I was able to start traveling as a PA, which you can do as a nurse, but traveling and finding different travel opportunities and different specialties just made me be able to create my own life and schedule, and, you know, like work on my terms. So I really love the flexibility of the career.
If you could go back, just to the very beginning, with the information that you know now, would you ever consider going the MD or nurse practitioner route?
No, no, I would not do that. But sometimes I think about it, just because like I'm like, you know, that's the one thing I hate, like kind of giving up on, or feeling like I gave up on something. So it's just to kind of complete it out. But it's not because, yeah, I would never consider actually doing it, but it's just like, oh, you know, like I just don't like feeling like, oh, I just didn't do it. I feel like, you know, and it's probably also because of just my journey as being first gen and not really fully understanding, you know, how things work in college and like college classes and acclimating. I just wish that I would have given that class a chance, because I dropped the class and I switched my major. I wish I would have done more. I feel like the me now would have done more to push myself to succeed. But at the same time, I feel like it all happens for a reason. And I gave myself time to explore and to grow, which I think is even more important than just trying to like do your best and like excel and, you know, have that type A personality of like just achieving. No, like you want to grow, you want to give yourself time to come into adulthood and experience things and experience those growing pains and get life experience. And I think that's what most important that I got from it. So yeah, no, I probably wouldn't change anything.
That's very insightful. Yeah, definitely. And I can definitely understand that sentiment with just completing things. You don't want to feel like you left it just at
Yeah,
one you like to kind of start what you finish in the end.
exactly.
Our next question, kind of on a similar thread, I think you might have mentioned this earlier, but just in case you didn't, do you like or do you prefer working more so in urgent care or the ER?
Definitely the ER.
Okay. And then what's the reasoning behind it?
Because let's see, what the ER is kind of more exciting. The urgent care, okay, the ER is, and you have more support in the ER. You can have more support in the ER, and then the urgent care is just like, to me, the urgent care can be a little bit more fast paced, and especially if you're alone. Usually in the urgent care, it's 1 or 2 providers, and it's like sometimes it's like this, like they just keep rooming patients. But the ER can be a little bit like that, but the ER, it seems like you have a little bit more support and you can like work a little, like you're not so as pressured. I don't know, to me, but the urgent care is just so like just throwing patients. I don't know. You just don't really have time to breathe sometimes in the urgent care, at least from my experience. But I haven't worked at urgent care that much, but it can be like that. Some of my urgent care, especially since COVID, has been more virtual stuff. So, which then is like that. Like it's kind of like in and out, you hang up on one patient, then another patient, you have to pick up a call, but yeah. And then the ER just like more fun to me. I like ordering labs and, doing all these different things too, so.
All right, a few more questions, just to
No
wrap up.
problem.
So, we had a few sessions actually earlier, about PAs, and lately we've heard about like residencies after PA school. So in your case, did you have an ER residency, and is that available in general?
Yes, residencies are available, like residencies or fellowship programs. I did not do one. You don't necessarily have to do one to get into the ER. I did have a hard time getting a job in the ER as a new grad. That was not my first job. My first job was actually like, it was in an urgent care, but it wasn't actually like real urgent care. It was weird because it was like a newly open urgent care and we didn't have that many patients. And then I went on to do addiction medicine because it was just weird. But I could not get a job for the life of me as a new grad. But I was also living in South Florida, which is like super saturated and can be like hard to get a job in the ER. So I had to work for a year to get experience. And then I got a job my second year in the ER. And I actually didn't start until 2018 because it took some time to get credentialed. But yeah, it took a while. And was that the question? Sorry, I got like lost.
No worries, no worries. That was right. It was just about if you had a residency, which you said you didn't.
Oh, yes. No, there wasn't. Yeah, there was not a residency, but you can do one. While I was looking, that's where I was trying to get to. Because while I had such a hard time getting a job, while I was like exploring different opportunities, an opportunity came up in California for a residency program, and I almost took it, but then I was just like, California is very, very expensive, and I'm coming from Florida, and I just decided not to take it and keep working at home. But I decided not to do one, but there are definitely ones. But with those type of programs, you also just have to remember you won't get paid like a full salary or hourly. You'll get kind of like, it'll be a low amount, lower than what you would typically make, because they're basically like kind of training you. And you can kind of think of it as like an extended like rotation, but it's very hands-on and stuff. But yes, I didn't really like that aspect. But then they, you can negotiate pay and everything after the program.
Okay. So in general, do you think it really just depends on where you are, like your circumstances and the location, to determine whether it's worth it?
With residency programs, I mean, I would say it's not just that, but if you want to do it, like, I don't think there's anything wrong with them. I think like, certainly I think it's really, really beneficial for like for highly specialized areas like cardiothoracic surgery. I think that's something that like I would definitely like encourage people to do residency programs in that, like to get more experience. But the ER, like working in the ER, I mean, it's plus or minus if you want to. It wouldn't hurt you to do one. And just depending on what you want, like if you think that, you want the extra training or the extra help, sure, definitely nothing's wrong with it. And the only reason I didn't do one is because I couldn't handle the cost of living, and offset with the pay. But yeah, so it just depends on the person. Everything can depend on also where you live. But highly specialized, practices or specialties, yes, like I said, the cardiothoracic surgery or like types of neurosurgeries and all that, yeah. And our traumas, trauma trauma surgery, I think those are great to do residency or fellowship programs.
Mm-hmm. Actually, we had now that I think about it, we had coincidentally a program director for emergency medicine. I just had missed the specialty, but yeah, she was also in emergency medicine. So what a coincidence.
Oh, awesome.
Yeah. Two more questions though, if you don't mind, just before.
Yeah, no problem.
The first thing is a student asking, what was your first introduction into the general urgent care and ER specialty? What was the first like experience within that field?
The first introduction was on rotations. So my my second ER was like my second or third rotation. And I was scared. Like I was terrified. I did not think, because I'm typically like demure, reserved, like quiet. Like I didn't think that I would like the fast-paced nature, like having to kind of like think on the spot and just be like on go. But I found that aligned with my personality. So my first experience was just on rotations. And then for my family medicine rotation, I decided to do urgent care because I liked ER so much and I knew they were similar. So I didn't actually do a actual full family medicine. I actually went into urgent care as my family medicine. It was able to count for that. And I did really like that urgent care. And I think the fast-paced nature of urgent care also depends on where you work too. And then I ended up doing an ER rotation as my elective rotation as well. So I did like 9 rotations, and 3 of them were like related to ER and urgent care. But my first experience was on rotations in PA school.
All right. And the last question to end off our session on is, what does a typical day on the job look like for you? I know you not only work as a PA, but you're also founder of MedSembly, so it would be a bit different. But on the job specifically, what would you see in a typical day? I know it's not necessarily typical, but what's an example maybe?
Yes, definitely. So, typical day, I would, of course, clock into work. Just thinking about like my last gig. And for ER, you typically either work 10 or 12-hour shifts. I'm not a big fan of 12-hour shifts. I prefer to do like 10, but yeah, you work your shifts. If you work 12 hours, then you have 4 days off. You work 3 shifts. If you work 10 hours, then you'll have 3 days off. You'll work 4 shifts. But I'm a travel provider. So I kind of pick my own shifts and, the days that I want to work. But I would work like 10-hour shifts. So I'll clock in at our charting system, which is Epic. And from there, you'll clock in and you'll see like the whole tracker. You'll see the tracker, which has like the patients that are in the ER, patients that are assigned to beds and where they are, their status. You can see patients in the waiting room. But just basically tells you like what's going on in our department. And you can see other departments, but then you can open the chart. You can see patients specific charts. You can assign yourself to patients. So I'll go into work and log in, and then I'll see patients that need to be picked up that are either still in the waiting room or in a bed but hasn't been assigned a provider. So I'll pick that patient up. And then I'll open the chart up, and I'll first look at their vitals and their chief complaint, and to give me an idea of like, that's what you're going to do for all your patients. You're going to look at the chief complaint and the vital signs. And then you can choose to also skim through the patient's chart at their past visits to give you an idea about like, their past history and, if they're like a frequent flyer, or if they, never been to the ER, like kind of just give you an idea of what you're working with and, how this patient may present, or just the patient's medical history, just to prepare you. So I'll skim through, do all that, write a list of all the patients that I'm about to go see, and then I'll go see them. And when I go see them, knock on the door, put some sanitizer on or wash my hands, introduce myself, then do my history and physical. And in the ER, everything is focused. So you're not going to ask them every single thing in the world. You're seeing a ton of patients at once, and it's very busy. So you're going to just focus on, what you think is going on, and ask necessary questions around that chief complaint or around what you're suspicious about. So I'll do my history. You want to do a proper history and physical though. Keep it concise, but thorough, but concise. I don't know how to make that make sense, but and then you're going to do your physical. You're going to, of course, do a physical on what you feel that you need to. So if the patient's coming in with abdominal pain, you might not, do a neurologic exam because it's abdominal pain, or you might not touch the ankle because they're having abdominal pain and you want to be focused. So you'll do your physical, you'll do your history, and then you should have like a lot of what you need to, help in your decision and guide you in the next steps. So then I'll basically then go around to every single other room for patients that I have to see and do the same thing. So I'll do all that at once, and then I'll go back to my desk, and I'll start ordering labs, tests, imaging on all these patients, one patient at a time. So I'll open up, patient A, order all the stuff that I need to order for them. So all the labs, order medications if I feel that they need medications, order imaging if I feel they need imaging, and then go to patient B, patient C, patient D, and do all the same things. And then after I order labs, tests, imaging, medications, IV, all of that good stuff, after that, I would then do my charting, because charting, doing your notes is like if somebody didn't ask me what I dislike about being a PA or dislike about healthcare, it's the charting. Like, taking notes is so annoying and it's so time consuming. So I start ordering my labs and tests and everything, make sure the patient is okay, and then I'll spend time doing my notes, because by the time you're done with your notes, even done with notes on one patient, you'll start getting all your tests and stuff back. So that means you already start knocking out your notes, so you don't get bombarded and get held back in your stuff with notes and have to stay over. So you don't have to do that, because you've already started your notes or you've completed your notes, and now you can see the results as they come in. So that's my flow. Everybody's going to have their own flow. There's no right or wrong way of doing it. You're just going to figure out what works for you. That's what works for me. So by the time I'm done doing like a note on a patient, their results will be back. And then I'll go over the results, their lab, their imaging results. And then that's usually when I talk to the doctor about what I think is going on, if I feel I need to, like if I'm unsure about a test result, if I'm super concerned, if I feel the patient needs to be admitted, I'll call the hospitalist, or I'll call a specialist if I'm concerned about something, or if the patient needs to be transferred. That's the time when I actually do the most talking and consulting with the physician as stuff starts to come back, because you're seeing things that you didn't really expect to see. Say a patient comes in with chest pain and they have a GFR of 10, and oh dang, this patient probably needs dialysis and is in renal failure. So yeah, that's when everything starts to get uncovered, and you'll need the assistance of your team. And then from there, a disposition is when you either discharge, admit, or transfer a patient. You decide where the patient's going to go, the patient's diagnosis, the patient's treatment plan, and all that good stuff. So then we do that, and then I basically do that for all the patients, and that's just keep doing that all day, every day.
Yeah. Well, this was such a great session. Thank you again, Rodeline. I just wanted to end off with a few last reminders for our students. We have a quiz, so that quiz is now posted in the chat box, the same area, either to the right or to the bottom of the video that you're watching now. So it's in the same place that you posted your questions, and you can go through that quiz to receive your certificate. At least 6 out of the 10 or more questions are needed for you to pass. So like I said, it's available in the chat box, and it's also on our website. If you go under website, under the virtual shouting page, there's going to be a Monday and a Thursday quiz. Click onto the Thursday quiz, and that quiz will be due next week on Wednesday, November 23rd, just the day before Thanksgiving at 11:59 p.m. Central Standard Time. And like I said, after passing that quiz, you'll receive the certificate. It's going to be sent to the email inbox, or the inbox of the email address that you've listed on the quiz. So be sure it's one that you're comfortable with. We recommend a personal email. If you don't find it either in your inbox or your spam folder, you're always free to email us. Our contact again is shadowing.h4h@gmail.com. And for our next session, we're going to have Dr. Kursine, who's also in the Atlanta area. She is the Director of Supportive and Palliative Care Outpatient Services for Emory Healthcare. So she's going to be joining us on Monday, November 21st at 7 p.m. Central. Again, you can follow us on Instagram and join our listserv to hear more from us. We have a subscription form at the bottom of one of our pages on any of our web pages on the site. And also, Rodeline shared her Instagram contacts for MedSembly and her personal Instagram, her email too. MedSembly is a great resource. There's mentorship and more. So if you'd like to hop on, and I think there's an app too. So if you'd like to hop on to their page, they have more information. I think it's at your bio link, right? The link tree that you have on your bio.
Oh, yes.
Yes. So if you'd like to hop on and take a look at what there is to offer, especially for those pre-PA students out there, it would be great. But yeah, we definitely thank you so much. This was such a great session, and it was session number 50. So definitely a session to remember. We really do appreciate your time, Rodeline. And by the way, one quick thing, next week, since we're going to have Thanksgiving on the 24th, which is a Thursday, we won't have a session on that day. Just a quick note. But yeah, thank you so much again. We really appreciate it.
Thank you, guys.
All
Thank you.
right, take care. Everyone have a great night.